Testing 1 2 3. Testing 3 2 1.
This is Reverend Ralph Emerson, one of the board of managers. And I just wanted to
My name is Lauren Poe, and I'm the executive.
All right, thank you. Welcome, everybody. I'd like to have you join us at the virtual Board of Managers meeting at 1 p.m. Thursday, the 13th of May, 2021. Jennifer Massey, if you would join us for the opening prayer and then the Pledge of Allegiance.
Please join me in prayer. Most holy God, we come to you asking for your guidance, wisdom, and support as we gather together today. Help us engage in meaningful discussion. Allow us to grow closer and nurture the bonds of community. Bless the work we have done and will continue to do for JPS and the communities we serve. Let us all be reminded of the mission. Let us be unified in our quest to be for and with those we serve, as you have called us to do. Fill us with joy as we receive your gifts with open hands and generous hearts. We ask these things in your name. Amen.
Amen. If y'all could join me with the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Do we have any citizens?
No, sir, we have no citizens.
No citizens. The next thing, as item Roman numeral 4, is the approval of minutes. I'd entertain a motion to approve if there's no changes.
This is Dorothy, move approval.
Is there a second?
Second by DT.
Discussion? All in favor, please say aye.
Aye.
Those opposed, say no. Not hearing any no's, motion passes. And we have approval of the minutes. For my board chair report, it has not changed. It's still thank you, thank you, thank you. Once again, I could never even start to name all the people, etc., that help our patients. So all I will keep doing is just say thank you, thank you. Robert, you're up.
Thank you, Dr. Weber. You bet. Thank you very much. I think I'm going to start a little bit differently, and it dovetails really well, Dr. Weber, into your thank you comments, which we greatly appreciate. Jeffrey, if you don't mind, I'd like for you to run two of the videos, but the first video I'd like for you to run is if you would run the thank you that our board members provided to the employees at JPS. I think all of you on the board may have seen this. Many of you participated in it, but I want you all to take a look at this. This is the first video. Y'all are going to see two. This is your colleagues and their thank you to the JPS team, and we are grateful for y'all. But then we kind of have a little bit of a surprise second video. So go ahead, either William or Jeffrey, and run that particular video.
This is Reverend Ralph Emerson, one of the board of managers. And I just wanted to express my thank you to the GOAT of healthcare, G-O-A-T, the greatest of all time. I thank you so much for your commitment. I thank you so much for your desire and zeal. You are much appreciated and revered based on the work you have performed. God bless you, JPS.
I'm Amanda Rizola, JPS Health Network Board of Managers, and I just want to give a big shout out, heartfelt thank you to all staff members, administration, nurses, doctored, allied, janitorial staff, everybody who has touched the lives of our Tarrant County residents and made their lives better because of your service. And we are making Tarrant County healthier, active, and alive. We thank you so much for your time and dedication. now and in the future.
I want to thank each and every one of you for being the glue that helps hold this place together. Happy Hospitals Week. Now more than ever, after a year of what we've had, each and every one of you have done a superb job and really have made JPS's light shine bright. Thank you all.
I want to take just a moment to thank JPS leaders, staff, physicians, everybody involved in JPS for the outstanding job you've done. It's been a very difficult time, and you've all rose to the occasion and excelled in protecting the health of our citizens. I am proud to be on the board. I'm proud to serve you, and I wish God bless to all of you.
It's been a long road since this pandemic started. We recognize that there have been so many sacrifices made, despite the unknown and the fear in the beginning. You continue to show up for your patients, for JPS, and for our community. You are the core that holds JPS together when we proudly say, powered by pride. And for that, we thank you from the bottom of our heart. Happy National Hospital Week.
I'm going to make this very simple. I just want to say thank you to each and every one of the members of the JPS team for the outstanding achievements and accomplishments they've had during these trying times and during this last 12 to 14 months. I just say thank you. Thank you for your selfless service to the Tarrant County community and for the sacrifices that you've made to your family, to your friends. And although I know it makes you feel so good for the help you've done in our community, you likewise have suffered during these times also. So again, I'm so proud to be on this board, and I'm so proud to take this moment to say thank you so much for what you do.
To those of you board members that helped us put that together, we are grateful. We know that not everybody could put that together for us, and all of us have busy schedules, but it really speaks to the pride that this organization has. It really speaks to the way you've got a board that cares. It really speaks to how we find ourselves in the midst of bedside care, patient care, the policies, the procedures, the legal aspects of an organization of this magnitude, the financial aspects of this magnitude, the political issues that we have, the interest that taxpayers have. So it's been an amazing journey through a pandemic. But I can tell you as a CEO of this organization, I would never want to even attempt to go through a pandemic and the challenges we've been through in the last year and a half without this board and without the 7,200 people that make it possible. So I don't know who's running the board, if it's William or if it's Jeffrey, but I want you to run the second video. This is a bit of a surprise to you board members, and I want y'all to sort of watch this. This is how we feel. So if you'll run that second video.
Is this the one with
My
you?
name is Lauren Poe, and I'm the Executive Director of Strategy and Business Development.
My name is Jeffrey Wright. I'm the IT Service Manager.
This is Raj Gandhi, your Trauma Medical Director.
Hi, my name is Christina Luna. I'm an LVN and I work in the Orthopedic and Podiatry Surgery Clinic.
Shane McKee. I'm the Director of Learning and OD at JPS.
To the Board of Managers, I just want to say a sincere thank you for your unwavering commitment and your support that you give us each and every day.
I remember when we started down this road in 2009, finally going to be a level 1 trauma center. That kind of support, it does not come all the time. However, our board has been extremely supportive, and I thank you all for that support.
Because of your support and your leadership, we at JPS are able to provide high quality care to those patients that need it most.
Each of you have ensured that the residents of Tarrant County have a place they can call their medical home.
I wanted to thank all of you board members for everything you do to support this hospital, our mission, our values.
Especially during Hospital Week, Thank You Week.
What we do wouldn't be possible without everything that you guys do for us.
Once again, I just want to say thank you for being a member of our Board of Managers, and most importantly, for changing lives.
Chuck Weber, you thank us. We want to thank you on behalf of all of us at JPS, the 7,200 strong people that wake up every day and come into work we appreciate you as a board. I get to see you all once a month. I get to talk to many of y'all 3, 4, 5 times a month, and I am grateful. I'm grateful for the professionalism. I'm grateful for the mentoring. I'm grateful that the direction that this board has given us. So you all can download that. You can have it. Those people that were on there, from Lauren to Jeffrey to Dr. Gandhi, they're really just a representative of 7,200 people that appreciate what this board does day in and day out. And our team knows that it's volunteer. Our team knows that you spend a whole lot of time on the JPS board, and sometimes that recognition is not as strong as it probably should be. So we, on behalf of the staff, wanted to thank you all as board members. So thank you all very, very much.
Robert, may I interrupt you a second?
It's all yours, Dr. Weber.
I was hoping that we'd get to see video number 3 that you have elected not to show in honor of Nurses Week.
we will potentially put that one up. I'll ask Diana Brodeur if she can, before I end my report, if she might be able to get the team. We did what Dr. Weber is referring to, and Dorothy will appreciate this from her nursing days. We put a little video together. The nurses actually wrote the script, and I was the one that they were dealing with. So we have a nurses video. So I don't know if Jeffrey and Diana can get that up soon enough before I'm done, but Dr. Weber will definitely try to get that up.
No, that's not necessary.
Let me tell y'all a couple other things that really has been happening. As you saw by the video, it is hospital week, and a hospital week is kind of hospital year. We don't ever want to go a day without appreciating the team that's at JPS. And as many of you all mentioned in your videos, from Reverend Emerson's comments and from Roger Fisher's comments about the glue and the strength and who we are and the greatest of all, those are really powerful to us. And so this week, we've set up a variety of things that are designed to make people smile. There are coffee bars set up for people to just take a break and have a sip of coffee. Tonight, we are having movie night where JPS family members can come out and see a family movie at the drive-in theater so that they can just relax for a bit and have some popcorn and enjoy the evening. As you all know, it's a stressful place, and it's been particularly stressful during the pandemic. So to go out and see a family movie for everybody and their children, that's a nice situation to just smile. So we've done a variety of things. We've had virtual scavenger hunts. We had on Tuesday the largest amount of thank you notes probably ever written in the history of thank you notes. Managers, directors, line staff, doctors, physicians, nurses, everybody in between wrote thank you notes for people that meant something to them here at JPS. So we've had a huge amount. At the same time, we're doing Hospital Week. This year, Nurses Week has become Nurses Month. So Dorothy, we're advancing since the days you were here. We don't do weeks anymore. We do months for our nurses. And when you have just under 3,000 employees who are nurses, you listen to them and you do what's needed. So we are having in the midst of sort of Nurses Month, and we've had videos and we've had a lot of fun for our nurses and trying to show people not only how much we care, but their true value. And we understand it and we don't want to miss a beat. So we have that going on this month as well. Dr. Weber raised the Diversion Center. I'll talk a little bit more in close, but the Diversion Center is an effort that many communities in Texas have done. Mr. Montgomery was appointed to a committee along with myself, appointed by the county, to look into a diversion center. And what that really is to take individuals that probably should not be booked into a jail, whether it's a mental health issue, behavioral health issue, or any other issues that probably should not be jail incarcerated, and find a place where they can be diverted to. so that you're not clogging up the legal system in the challenges for people that probably shouldn't even be in that process. They should be seeking help in a housing situation. They should be seeking help in medical. They should be seeking help in a variety of other ways. I think those are pretty important. So we've been working with the county. The county's been working with District Attorney Sharon Wilson. Roy Brooks has been an advocate and a fighter for this for years. Glenn Whitley, our judge, has put a lot of effort into this. And so we're trying to figure out the governance of a diversion center, but obviously JPS would be affected by it. There aren't any other public hospitals in Texas that actually run a diversion center. They're actually run by other entities. And MHMR would have a big play in that. If you all remember Wayne Young, who used to be here at JPS, he went down to Houston and he is their CEO of their diversion center, along with a lot of other responsibilities that he has. And he's been announced a nice counsel to me on giving the county suggestions on how to do a diversion center. So wanted to give you guys an update on that. Also wanted to let you know that you will see on your screen a new name. You will see on your screen Mark Hallman. Mark is joining us. He is a 7-day employee, well, an 8-day employee of JPS. I mentioned to you all Mark before. Mark joins us from the Sunshine State of Ohio, which gets sunshine about 12 days out of the year and cold the other. And Mark is going to serve as our Chief Innovation Officer. It's a new role for JPS. And when we look at the challenging issues of joint ventures, and we look at the challenging issues of how to diversify funding projects for JPS, and we look at the possibility that the board would look into that Charlie and I and Steve and Trent have spent many years dealing with should we or should we not do an apartment complex for affordable housing? What does that mean for commercial development? What does it mean to look at developing our 6.5 acres on Main Street with the possibilities of a research park and others? Mark is well positioned to do that. His work at the Cleveland Clinic and other places put him in a great position to do that. So y'all will get to know Mark. Our team is just getting to know Mark, and every comment about Mark is wonderful. We've put Mark quickly into Thank You Week. He stood at the door last night at shift change from about 5:30 to 7:30 with a poster that said thank you. And all of our executives have done that, but the rest of his colleagues were prepared for it. Mark had about 10 minutes to know that was one of his duties, is to stand at a door with a sign that said thank you. So we're greatly appreciative that he's joined our staff, but I didn't want you to be surprised when you saw a picture and said, who's Mark Hallman and why is he consulting for us? He's not, he's part of the team. Just wanted to let you all know, and you all will get to know Mark over time, but he's been a neat asset thus far to us, and he will continue to help us immensely.
Robert,
Dr. Weber,
let me interrupt you a second.
Yeah.
Mark?
Yes, sir.
Do you root for any particular football team at the college level?
Of course. A Buckeye at heart.
And that would be who?
The Ohio State University.
Oh my gosh. Jeez.
The problem that you have, Mark, with that, and your answer is correct, but the problem with that is you have a few A&M folks on here who occasionally will see Ohio State. You have UT who pretends to see Ohio State, but you really have the problem of Dr. Weber. Dr. Weber is a Michigan boy, and he has the watch and the colors to prove it. So during that time period, we'll take you and Karen Duncan and put you in a separate room from Chuck Weber during the big rivalry between Ohio State and Michigan.
I think that's a good idea.
Yeah, exactly. So, Dr. Weber, in your efforts to make sure that we are constantly addressing your needs and your interests, unfortunately, we have the video. So we will show you the Nursing Week video. Jeffrey and or William, if you will put that video up, we'll unfortunately let you board members see what your CEO does in his spare time.
Yeah, this is the real Robert Early.
Thanks. 3,000 incredible people, and they're all here at JPS. They're called nurses. None are better. They take care of you. They make sure that everything is perfect. Our nurses at JPS can compete with anybody, anytime, on any level. Caring, loving, appreciative, that's it. Our nurses are better than you're ever going to find. In fact, the care that they give, you don't even notice that they're giving you care. It is incredible. I can't feel my arm anymore. You can't even know that they're around. That's the kind of care. Is my hand supposed to feel that way? Because I can't feel my hand. You won't even know that they're dealing with your blood pressure. 300 over 50. I don't know if that's good, but I'm not a nurse. But the nurses that are here, they would tell you that's good or bad. Thank you. I don't know that that was the right place. Okay, that kind of tickles. That kind of tickles. That's really cold. Again, the nurses at JPS could not be better for any reason, for any cause. They're never going to be better. You can find nurses in other places, but you're not going to find better ones than the ones we have at JPS. Thank you. JPS nurses, none better. I promise you all as board members, I will stick to my day job, and acting is obviously not going to be my skill set. But that gives you, it gives you an idea that what we want to do at JPS is smile, and what we want to do. And if I can do anything to help our nurses or our team or our staff, I'll do it in a heartbeat, even at the risk of looking like an idiot, which I can do quite well. So wanted to let you all know that is my report, Mr. Chair. If you all have any questions, I'll be happy to answer any.
Robert, I don't know much about medical and blood pressure, but I do know that it's like your golf score, the lower the better.
Good. I knew I was in trouble that day. But here's the good news. My blood pressure ran that high and it wasn't a board day. So that's a good sign.
Robert, what he didn't tell you is his golf score is 300.
Yeah, I'm not going to get into y'all's golf scores.
But Robert,
yes, sir.
Reverend Emerson, on the center that is being proposed, has that the scope of that facility, has it been finalized yet, or is it still in the making?
It's still in the making, very much so. I know that Zelia and the judge and I believe Commissioner Brooks and a few others from MHMR toured facilities in Arizona and Houston and San Antonio to get an idea of how things, the prototype. So it's very much still in a stage of, one, geographically, they don't know where they want to put it. Secondly, they don't know who's going to fund it. And third, I think they're trying to deal with whether there's an actual building or leasing it. And I think where the county really wants to go, and this will be the county's decision, I think they're going to initially want to lease space for a diversion center and then figure out exactly where to go from there. And my video just popped off. There we go. Yeah. I think all of our videos just popped off. So no, Reverend Emerson, they're not gotten those specific details, but they did discuss it last Tuesday at the court. And I think they'll have a couple other meetings to discuss it and then come out with the court's decision.
Okay. All right.
So, thank you. Good question. So, any other questions y'all have? Yes, sir.
So if I have some concerns or comments, should I direct them to Roy?
Yes, sir. Because he will ultimately, he and his 4 other colleagues will ultimately make the decision on the diversion center.
Okay.
100%.
All right.
And they've told us very clearly that that's going to be their totally their decision, which we're fine. I mean, you have us, you have the district attorney's office involved in it, you have the sheriff's office, you have MHMR. There's no way any of us could make that decision, so they really are. My recommendation to them, and I said it at court on Tuesday, my recommendation is that the county, who has much greater authority over MHMR and the hospital district and the sheriff's office, they run the facility and they contract out for services. And that's a model that I know that others have done, but that's just my opinion, and others might think differently. I know Zelia and I and Karen have discussed it at great length. We certainly see it that way, but they may choose to do it differently. I was listening to their comments at the court, and I truly could not tell you exactly which way they want to go, but I know they're going to give it a great deal of due diligence. So any comments, Reverend, that you have, I would direct them to Commissioner Brooks. You can give them to me and I'll give them to him, but your ability to call him is wonderful, and he's your he appointed you, so feel free to call him.
Okay, all right.
You bet. Thank you. Mr. Chair, that is all that I have, and if you want me to introduce the next subject matter, which is the department update, I'll be happy to do that as well.
Please, if you would.
You all know you met Doug Chung. Doug is one of our relatively new members, although at JPS, you ceased to be a new member of the executive team after your first 24 hours at JPS. So Doug has been initiated well into JPS land. On Monday, which is not a video we will show, on Monday, Doug and a few of his colleagues did a video for all of his friends, and it will be a video that if you all need anything from Doug, I'll be happy to show you the video. But he was a former member of the JPS ABBA team, and he got drug into a situation by the persuasion of J.R. Labby and Laura Burnside. But it was a video that made everybody laugh, and that's, again, our purpose. Aside from Doug's ability to do that, he's an incredible executive for this team. We were lucky to have Doug, and Doug joined us from HCA facility in Houston, and he really is an asset to this team. And Doug is taking over some areas that you all as board members know we've had some challenges in the past on, and Doug is addressing many of those challenges in his responsibilities over lab and pharmacy and some really tough areas at JPS. Doug is doing an excellent job. And what I asked Doug to do this time is give you a rundown of some of the things that we're doing in our clinical pharmacy program. Many of you may not be aware of clinical pharmacy and what we do. So we've got a few short slides for you and a little bit of a description from Doug. So Doug, if you don't mind, why don't you go into the presentation?
Absolutely. Thank you. So, as Robert said, this was one of the areas when I first came on to JPS, one of the first areas I was actually introduced to, and I was very surprised and pleasantly surprised in the investment in clinical pharmacy for our patients and for our community. And I just want to say thank you, honestly, for your commitment to this program and the investments over the years into clinical pharmacy, because it is at a level that I've not seen in my experience at other hospitals that I've been at. And I truly believe in the power of clinical pharmacy and what it really can offer our patients in our community on a daily basis. So, and I do just want to give a shout out to Elise. She is our director of clinical pharmacy, who has been, here since the inception of the program and has helped really kind of provide an education to a lot of our folks and to myself as well, just on some of the intricacies of the program. So next slide, please. So just at a very high level overview of the program, our clinical pharmacists verify about 75,000 medication orders per month that come into the hospital. That could be from our advanced practice providers or our physicians or our residents. That results in about 16,000, I'll say, doses of medication given on a daily basis in the hospital. So a lot of volume and a lot of just a lot of room there to really provide care at the forefront, right, for our patients. But our clinical pharmacists are touching every single one of those orders and making sure it's going to the right patient at the right time, via the right route, et cetera. There's really two big buckets of clinical pharmacy that we have here at JPS. It's our inpatient and our ambulatory clinical pharmacy program. So our inpatient program consists of about 32 FTEs or full-time equivalents, and they provide 24/7 coverage across all of our inpatient floors and departments, which again is a unique aspect to our program. I've been at other hospitals with clinical pharmacy. However, oftentimes it is minimized to only an ICU level of care. And here we provide 24/7 across all departments. Something else that's very unique to our clinical pharmacy, our inpatient clinical pharmacy program, is they actually respond again on a 24/7 basis to emergency traumas, to strokes, STEMIs, code sepsis, and any other cardiac emergencies. And they are there at the bedside providing an additional level of support to our caregivers. They might be mixing emergency medications at the bedside. They may be recommending drugs to our physicians given the state of the patient's condition. And that is, again, something very unique and something that I'm certainly very proud of the team for being able to provide that coverage and additional support to some of our most vulnerable patients in an emergency response basis. In addition to the numbers that I showed you up above around the medication orders, they also perform our inpatient pharmacy about 700-800 clinical interventions per month. So what clinical interventions that bucket really consists of is oftentimes patients might come in, get a lab, and get something cultured, and it will come back as a bug of something that we weren't expecting. Our clinical pharmacy receives every single one of those results from our lab and then makes a suggestion to our physician saying, hey, we could actually switch this patient from antibiotic X to antibiotic Y, and the patient is going to do better off because of that. That's just one example of many things that they do. They also check for to make sure that patients are receiving the total dose or the therapeutic level of drug that they should be, again, through monitoring labs and being part of that multidisciplinary team on a daily basis in all of our inpatient floors. From an ambulatory perspective, the team's about 13 FTEs deep, and they provide actually one-on-one clinical care in our community health clinics. And last year, on average, they've done about 24,000 ambulatory care visits, and I'll expand on that in the next couple of slides. So next slide, please. From an inpatient basis, really consists of broken down into 4 major areas. So I told you a little bit about rounding and the fact that our clinical pharmacists are at the bedside with the multidisciplinary team reviewing the plan of care and understanding and providing input into medications that the patients are on. They're also performing medication reviews. As you know, board members, a lot of our patients could be on multiple different medications at a time, and the pharmacists are doing those checks to make sure no drugs are interacting negatively with each other and making, again, suggestions on what could be improved through a medication review. From an education standpoint, really a multi-prong approach here. Our clinical pharmacists on the inpatient side are educating our patients and families, right? So if they're going home on new drugs or difficult drugs to start out on, they're providing that education. They're educating our nurses on any kind of drug changes, or there may be a product that looks a little bit different to our nursing staff. They'll provide that education as well. And finally, they'll actually, our clinical pharmacists provide a lot of education to our GME or our graduate medical education programs and our residents and fellows just to give overall classes on certain types of drugs and the interactions and why we should use drug X, Y, or Z based on the current literature. If the fourth major bucket, high-risk discharge prescription checks, really what they're doing there, again, for any of those drugs that patients may have been put on for the very first time, they're providing an extra level of check and an extra level of support to the team to make sure that the patient is going home on the right amount of drug and that the patient fully understands what some of the side effects might be to starting any particular drug. To the right, you see kind of some of the work. This is I believe it's a 3 or 4 year look back of a drug class called the fluoroquinolones, and that's a That's an antibiotic that, as you can see to the left, was used quite a bit in our facility. And once the FDA actually started releasing some black box warnings around this particular drug and particular antibiotics, you can see our clinical pharmacists received those. They took action around that, and then they started making recommendation to different types of antibiotics that might be better suited for the patient from a clinical perspective, and getting patients off of those drugs that may have more adverse side effects. And that's just a little power of what really an inpatient clinical pharmacy program can do. Next slide, please. From an outpatient perspective, clinical pharmacy, really the workflow that happens here. So a patient will see our physician, and then our physicians will actually refer the patient to our clinical pharmacist program to see them on a sometimes monthly basis, sometimes on a quarterly basis, to really hone in on a lot of the conditions that you see below. Sorry about the slide there, but they manage, things like type 1, type 2 diabetes, hypertension, CHF, HIV, smoking cessation, all of those types of disease states. And really what this also allows is, because the provider who may have diagnosed somebody new diabetic, they might need to see that person on average 3 to 4 times a year to get their insulin correct and to get their medications in the right place for that particular patient. They're able to actually refer that patient over to clinical pharmacy. The clinical pharmacist will do that work in between the physician, and that then frees up additional access for other patients to come in and see the physician on an outpatient basis. And so really it's a win-win. It's a win-win for our patients. It's a win-win for our physicians. And the clinical pharmacists actually practice underneath what we have are called collaborative practice agreements, just like a physician assistant, just like an advanced practice nurse. And so they're able to see the patient and then hone in on the medication levels that the patient needs in order to have the best possible outcome. I actually shadowed one of our outpatient clinical pharmacists, and I have to tell you, in that 20 to 30-minute interaction with that diabetic patient that we saw, I saw that clinical pharmacist perform, titrate somebody's meds, get them motivated to start exercising again, get them motivated to stop drinking, a bunch of soda that was spiking the person's A1C, addressing some of the potential depression issues, and just a whole host of things that the clinical pharmacist performed. It was just awesome to see, and I was just honestly blown away with the type of work that's going on campus every single day. Next slide, please. So some of the outcomes of our outpatient clinical pharmacy program, really you look on the left, that is measuring anticoagulation therapy. We are measuring that based on the patients that are in our clinical pharmacy program. On average, right, we're about 54, 55, 56, and has improved over time, percent of the time. We were able to keep those anticoagulation therapy patients within range of what they call time in therapeutic range. And it's a great improvement over time through that process of outpatient management that I just spoke of. In addition, on the right-hand side, you look at patients that were, again, seen in our clinical pharmacy program, have come to the clinical pharmacist with an A1C over 9. And after interventions and after seeing and follow through and titrating medications to the individual patient, you see the improvement and the reduction of A1C levels for the diabetic patients that are in the program. So again, just great results and great success there. Next slide. So really, that's a high-level overview of this program. I couldn't say enough about the team. It's a small but mighty team, and they really do make a difference on an everyday basis in a little bit different way that you might not have realized, and certainly it's one of those services that it just kind of they fly under the radar a little bit, but do they have an impact, and man, are they really affecting patient care and patient safety in a positive manner here at JPS. So with that, I'll have any questions, be happy to answer.
Anybody have a question? Go ahead.
I have a question, Doug.
Yes.
Is this the initiative that just inside the pharmacy, or is this part of the bigger scale from, chronic care management and then complex care, chronic care management, CCM, complex CCM type thing?
Sure. So the clinical pharmacy team does report through the overall pharmacy structure. However, having these types of resources is helping with chronic care management, right? And so it is not just looking at anticoagulation therapy and A1C levels. Those are just two outcomes that of that program, but they are touching patients that may be hypertensive for a number of years and need to have different types of medications managing their blood pressure, right? So they're absolutely contributing to chronic care management. But they are over the overall clinical, they are part of the overall pharmacy team. Does that answer your question there, ET?
I'm just trying to see where the proper handoff or collaboration between the two groups, the medical group and the pharmacy group, because it's the way that you source, like a better term, sourcing the patient. Do they show up and you deal with this, or do you strategically sit back and say, these are the population that I'm looking at, these are the one with 2 chronic conditions, or 3, these are 3 or 4 or 5, and these are the steps, so that, because it's also affecting how you do billing also as well, right? Because for the CCM, you only have 20 minutes per month to do certain things, and if we do more than that, we may be have some challenge with compliance and all that stuff also as well.
Sure. So this is more of on a referral basis. So the patients are identified through our primary care providers, and then at least on the outpatient side, right? And then they are referred to our outpatient pharmacies team to really see those patients in between, like an annual visit. Does that make sense?
Mm-hmm. Yeah, because it's a once a month thing, right? For coordination of for the CCM or the complex CCM, it's just depend on, is it 20 minutes a month, or is it up to 45 minutes or something like that? Or is this something that get the starter to get it started, get the process running, and then fine tune down the road to incorporate everything else together?
That's something I could actually follow up with you on. I know that if that'd be okay with you, I don't want to misspeak and how that is incorporated into our chronic care management program, but I do know that what they do provide is additional access to our patients and additional access for our providers to see additional patients over time. But I'm happy to follow up with you on that and get an answer for you if that'd be okay with you.
Oh, sure, absolutely. When I saw it, it's absolutely needed. I'm glad you guys going down that path. Wonderful job. I'm just trying to coordinate a bigger picture. That's all.
Absolutely.
Mm-hmm. Thank you.
Mr. Chairman, may I ask questions?
Sure.
Doug, thank you for that. That was a great insight. As long as I've been on the board, it's just fascinating to me how much there is to learn about JPS and the wonderful things it does. This is really interesting. Quick questions on the clinical interventionist or clinical interventions. Can you kind of describe for me the interactions between the clinical physician, pharmacist, and like the attending physicians? I mean, do they in consultation decide make some of these decisions, or do maybe the interventionist say, hey, wait a second, those are conflicting prescriptions, or there's a problem there? Describe those interactions if you could.
Yeah, so thank you I think you have it, hit the nail on the head there. I think it's a multitude of ways, and really they are part of the multidisciplinary team and care team as a whole. So a typical interaction might be, hey, we thought the patient antibiotic that we had them on is a very broad spectrum antibiotic, and it's going to treat all the different infections in the body that we think we have now while we're waiting for something to be cultured in the lab. That culture will then come back to the care team, and the pharmacist will check and say, hey, it's actually a gram negative, something. And they will then say, these are the best drugs that are available for that patient. And my recommendation to you, physician, is to change patient from a broad spectrum antibiotic to a narrowly focused antibiotic, which might have less side effects and be less harmful to the patient. So that's something that happens on a daily basis. They're also looking at, a lot of the drugs sometimes need to be dosed in a very specific level. And what they do, and a lot of them are metabolized through our kidneys. And what they do is monitor some of the different kidney lab levels and say, hey, we're giving too much, or we're not giving enough, or the patient can tolerate a little bit more or a little bit less. And again, they're making those recommendations to the attendings based on what they know the pharmaceutical background is of the drug and what they think it would be best at that given time in consultation with attendings on a daily basis. So I hope that answers your question.
No, it does.
Steve, we have the luxury of also, and Doug, that was perfect from an answer standpoint. We also have the luxury of having Dr. Alawi on, who's listening as well. And Dr. Alawi is going to work directly with the pharmacy team on a daily basis as her role from the clinician and seeing so many of our patients. And also some of the questions that DT had, Dr. Alawi sort of lives on a daily basis. So Dr. Alawi, do you mind just giving Steve and DT just a brief explanation on both of their questions as well?
Absolutely. Thank you so much. So, Mr. Nguyen, to answer your question about complex care management, the clinical PharmDs can actually bill on their own because they are considered practitioners. And so they don't sit under that umbrella of complex care management. But we do collaborate with them quite closely when we do refer patients to them to help us with the chronic disease management. And one of the benefits of having these outpatient pharmacists is access for our patients, right? Because very often as a provider, especially if I'm starting a patient on insulin, or I've got a patient that's got a difficult to manage heart failure or hypertension, I might need to bring them back every week to kind of help adjust these medications, but we might not have the time to do that. And that's where these clinical PharmDs are our greatest ally in being able to bring these patients in, whether it's via telehealth or in person, to help make these adjustments and then collaborate with us on any changes they're making to their medications and things of that nature. So I hope that answers your question about the chronic care management. And then Mr. Montgomery, basically when it comes to collaboration, they are our greatest collaborators. They do come back with recommendations that they come up with on their own. And sometimes we do enlist their help, right? And so it can go both ways. I'll give you a perfect example. Very often I'll have a message in my Epic in basket from a PharmD because perhaps I have sent a prescription to the pharmacy for a medication that is a different one that the patient's been on for the last month or so. And so they'll send me that question of, are you trying to make a change? Or do you realize you've got two medications of the same kind? And, very often it'll be, no, I'm making a change, but thank you for reaching out to me just to check. So we're not duplicating medication on a patient. So it's amazing to have that trust in this team to know that they're there to support us and help us as physicians and APPs on our side when we're making these decisions for our patients.
That's great. That's really great. So one last question related to that is thinking about the drug interactions, and Doug mentioned the literature that's relied upon. Are there other tools that you use? Are there software tools that that you can kind of help support some of your decision making and saying, these interactions are bad, don't put A with D because you're going to get a really bad reaction? Or are there tools like that to help reinforce what you're doing?
So Epic is amazing at doing that. So Epic actually does give us kind of a red or yellow flash warning of these medications might interact, or this patient has an allergy to a medication that's similar to the one that you're prescribing. Are you sure you want to move forward with your decision? And, you know, sometimes there's a similar interaction, but not the same interaction. So as a provider, I might push through and say, yes, I still want to make that decision. And then having that backup of the pharmacist going, are you sure? And you being able to say, yes, I'm absolutely sure. I feel safe and confident. The patient's been on this before and I know they tolerate it well, or whatever it might be. Works.
Okay, thank you very much. That's awesome.
Absolutely.
I have a quick follow-up question on what we were talking about. Once, you know, you have the team in place like that, is there a chance that, you know, you guys will be looking at formulary also as well, and then reference pricing, and then also looking at, you know, bringing back into formulary at times, because sometimes they have their own, physicians have their own, like a better word, physician preference item and all that stuff. Is that the intent, or beyond that?
So we actually have a P&T committee, and Doug can collaborate with me or answer with me on this, but we do have a committee that's made up of physicians, nursing, and pharmacy that actually gets any requests for formulary changes or adjustments that anyone is considering throughout the network. And they make a final decision on what makes sense, right? What makes sense for the network, what is cost effective for the network, what's the best option for our patients, and what's the best thing that we need to do for us. But we do have an entire committee in place. They meet about once a month and they make all those formulary decisions. And it is a very collaborative committee, including clinical PharmDs, but also pharmacists.
Okay, thank you.
Absolutely.
Let me expand on what you just said or asked, DT. When I was in practice, this program just got started, and one of the things they used to do, and I suspect they still do, is they look to put people on the medications that are on our list. Is that not true, Doug?
It is. It is. I mean, they are absolutely. Again, this team is part of the multidisciplinary team to support our physicians and attendings and residents, and they work with patients with that team at the bedside, right, to be able to make those suggestions. And I mean, ultimately, again, is you know, on the inpatient side is the attending physician's decisions, but oftentimes those recommendations are coming out of clinical pharmacy based on the actual picture of the patient, and they're part of that team making that recommendation.
DT, one of the many things they looked at was cost.
Yes, cost, but I think I was hoping, and I know we're moving toward more cost plus the disease that they have, because sometimes when you do a generic substitution, you know, for the most part, it'll be okay, but there's certain circumstances where it's not. And I was hoping this will get us closer and closer. But also, according to a lot of studies out there, you know, physicians remember about 15 prescription, and this will enhance that knowledge and help with some current, you know, new stuff on the market that, you know, the pharmacist can bring to the table also as well. So, no, it's great initiative that you guys doing. Just want to don't want to lose on the next opportunity to refine all of that formulary and all that stuff also as well.
Absolutely.
Absolutely.
We, Mr. Chair, we appreciate it. And again, what this effort is to do is each board meeting, we will bring you one of our departments that are clinical in nature and one of our departments that are non-clinical in nature. It's designed to be 10 to 15 minutes worth of information to give you board members updates. I know that Reverend Emerson started this when he was chair, and we've continued this tradition to give you guys updates. And Mr. Montgomery, I appreciate your comments, because I think as board members, if you just have the opportunity to go to various committees or come to the board committee, you may not get some of the aspects of all that JPS does. So that's part of what we want to do. So Doug, thank you very much, and the insights. And also on behalf of, you know, certainly all of us who work with your team, we're appreciative. You're right. They're a small team that does a lot of work, and we're grateful for them. So I appreciate it, Doug. And Mr. Chair, that's our departmental update.
All right, Doug, tell everybody thank you once again.
We will do that. Thank you so much.
Thank you. The next one I have is Roman numeral number 8, report from the Medical Executive Staff Committee requiring discussion, updates, deliberation, action, or approval. Cheryl Hurd.
Thank you, Mr. Chair. I appreciate the opportunity. I don't have any items actually for your approval at this time yet, but I do have another report as I gave last time, and I would appreciate the opportunity to present what the activities of the medical staff has been. So under our oversight functions, we did receive the most recent PSI 90 report, and it was approved as submitted by our quality committee. And Dr. Stevenson did present an update on the Joint Commission preparation. Dr. Elliott gave us a summary of the Academic Affairs Health Study that's going to be presented to the ACGME. And Ms. Clark also presented financial report. Additionally, Dr. Song with infectious disease presented a TB exposure plan, and we did approve procedure for such. And also, Dr. Van Johnson presented the patient blood management peer review process, and that's going to actually be incorporated into the new bylaws. Delineation of privileges and our ongoing professional performance evaluation projects have finally kicked off with our approved consultant, the Hardenberg Group. When the standardized and revised privilege cards are finalized, they will be sent to the credentialing committee for approval, followed by submission to MEC for approval, and then finally to the board of managers. Y'all will start seeing them here in this slot once we get through that process. Additionally, the medical staff committee minutes were reviewed and approved by the MEC, including medical record, utilization review, and physician excellence. In regards to our educational treats, we had hoped to hold one in June on the peer review process. However, given a lot of other issues that have come up in regards to Joint Commission and the clear visit, those types of things, that was postponed. And then finally, the bylaws committee met April 27th. They approved the revived bylaws with minor amendments simply regarding department divisions. On May 11th, the MEC did approve the revised bylaws with typographical corrections and minor revisions for qualifications for department leadership. And active staff notification was sent out on May 11th with the final version, including the summary preparation. I will be holding town hall meetings with all the active medical staff scheduled at different times throughout the day on May 18th with our consultant representative, Aaron Mullenberg from the Pulsinelli Group. And the general staff meeting has been called for noon on May 25th for approval. If approved, the new medical staff bylaws will be presented to the board of managers, and Ms. Mullenberg and Ms. Walker have been in contact on the best way to go about that. And that concludes my report. Thank you very much.
All right. Comments, questions for Cheryl? Anybody? Cheryl, thank you.
Cheryl, Chuck, Cheryl was able to do that entire report without one single breath. I'm very impressed. That was really good.
I noticed she was starting to turn a little blue.
She was. She couldn't have gone longer, but she did really well.
I agree.
Thank you. I try and be brief.
Okay, I'm number 9, other matters requiring board action update. First one is the acclaimed JPS strategic alignment engagement update. Jay York from Guidehouse.
Great. Thank you, Mr. Chairman. This is Jay York with Guidehouse. And first of all, I want to express our appreciation from myself and Mike Nugent, who's my colleague on this call, for having the opportunity to work with JPS, its leadership, board of managers on this engagement. To speak to the beginning of this whole meeting, I mean, it's really an honor to help you further your mission and the great work that you do. And having that kind of North Star is always refreshing. I also would be remiss if I didn't offer Mark a hearty welcome since I'm calling from Ohio. So good luck down there, and it'll be great to see you as your consulting partner.
Thanks, Jay.
You're killing me.
Doctor, we had this conversation, so all good. So to begin with, if you can click to the next slide, I wanted to give you a quick update of the work that's begun, so our engagement objectives and scope, and then how we're progressing on that, and then talk a little bit about our next steps and what we see coming along in the next few weeks as we work to conclude this assessment engagement. So next slide, please. Thank you. So As I believe everyone is well aware, we've been engaged to really perform a full assessment of the Acclaim medical group. And our approach to that is really to fully leverage the institutional knowledge and truly get to know your organization to provide, the best direction possible. So the work that we are engaged in is really focused on analyzing current performance with respect to operations, expenses, productivity, staffing, professional billing, and infrastructure. And what we have here for you is as we look at the outcomes of that work, the assessment's really going to be targeted at establishing operational efficiency targets and performance improvement initiatives, developing those strategies and tactics and plans that are clear and compelling and dovetail in with the work that's being done at the JPS level on strategy, and looking at a framework to assess that ongoing performance. And then finally, really designing an infrastructure to support this. So all of these things work very synergistically. One can be done without the other, but the powerful nature of this is really to bring it all together. And we feel like we've got a great opportunity to do that. So yes, please. Oh, sorry, I thought there was a question. So as we're moving through this, the progress to date has really been focused around initial data requests, which have been fulfilled, and our analyses are underway. This is generally what we consider to be a pretty big initial lift. Gathering the data from various sources in the organization takes time and effort, and we truly appreciate all the work that's gone into this from the various people within JPS and Acclaim. And then simultaneously with that, we had the opportunity to conduct 29 interview sessions. Some of those were multi-person interviews, but 29 interviews to really get a flavor for the history and nature of Acclaim, its alignment with JPS, and to identify, recurring themes that will play into the overall assessment and recommendations. And then ultimately, as I mentioned earlier, as we go through this work, we are fortunate to be able to coordinate with the strategy development as well as master facilities planning that's going on, so that all of these things remain aligned and give us a better big picture of progress going forward. Next, please. So just to give the group an idea of how we continue to move forward, as I told you, the data validation is continuing right now. That's usually about a 1 to 2 week process. We've got about a week left as we validate a lot of the granular level data. And simultaneous with that, our analysis and benchmarking has begun. So we do quite a bit of number crunching in that respect. And what comes out of the assessment, gives us some very good directional data and ties back to opportunities that we will identify and then speak to. As we start to close this out and utilize the analysis, we will work with the JPS and Acclaim's team to develop business cases and prioritizations. And then ultimately that will inform the deliverables and recommendations. So all of this working through the next probably 8 weeks to get to completion and share our findings along the way with JPS leadership, and then ultimately codify some of those recommendations and how we will move forward. So that is our brief overview of how we have begun and are proceeding along.
Jay, thank you. Does anybody have any questions for Jay at all? Hearing none. Jay, thank you.
Thank you, Dr. Weber.
For the update. We'll look forward to the next session.
Great.
Okay. The next one I have is the annual institutional review, GME, and institutional self-study update. Dr. Elliott.
Hello, good afternoon. Thank you, Dr. Weber, for this opportunity to come before you to give my annual report. Last year, we were only able to give you a very abbreviated summary of what we were doing, so we look forward to kind of combining the last couple of years and being able to give you a very brief report in terms of our academic affairs, graduate medical education focused annual institutional report. Additionally, we are charged by the ACGME, our accreditation body. We are in the window in the next couple of years to likely expect an institutional site visit. And so part of that process is also to perform what's called an institutional self-study. And part of that process that we are required to also, of course, ensure that we're engaging our board of managers in that. So in the latter part of this presentation, I'll be happy to present those findings to you and how our process worked in that area. Next slide. So just an overview, just a reminder, we are a sponsoring institution for 10 graduate medical education programs. Of course, we also have our partners for integrated and collaborative programs with Baylor University Medical Center and UT Southwestern in Parkland. And we're so happy to have over 200 plus residents that we also help to train and to be able to seek and provide care for our patients in our communities. Next slide. This is just a summary here of our accreditation status. We are fully continued accreditation. We are still in the process of reviewing certain letters with our program directors and our programs, and the GMEC will be reviewing those to review action plans as we do that annually to ensure that we're continuing this process. Some of our programs have received commendation, including our institution again, and so we're excited about that. We are in the window of site visits for 3 programs still. These were also additionally still delayed due to COVID last year, but we are preparing them through mock site visits. We've met with all 3 programs, family medicine, sports medicine, and geriatrics, and they're working on their action plans to make sure that they're fully prepared for those visits. Next slide. Just want to highlight some of our wins and benefits that we can't do this without you, and you guys have been instrumental in helping us to do this. Of course, we had to put out there our #1 teaching hospital, in addition to being the #1 hospital for America by Washington Monthly. But to have that teaching recognition was great for us to see that too. We also, of course, really are great to have our residents and our fellows alongside with our faculty and our nurses and all of our interprofessional team at the front lines, providing high quality frontline patient care. This is a high satisfier for all of our faculties in terms of engagement and satisfaction because of the teaching mission, and that the academic mission is a part of our priority here at JPS. Of course, for recruitment and retention, having high quality residents and hoping to retain a few of those for Texas and our communities, local communities, and for JPS. And of course, our advancements in research and scholarly activities are very true in terms of our wins and our benefits here too. Next slide. Also just want to highlight our partnerships, and we're so excited that we have worked with our finance department very diligently to seek additional funding. We're always looking for opportunities to be able to expand those dollars coming to us for financing GME. We were so pleased to be able to secure additional funding through graduate medical education funding, actually, through the state. And so we're hoping, of course, as we're in that state legislative session now, that we will see some of those things continued in terms of expansion grants for GME. But we were awarded $1.8 million for emergency medicine expansion, family medicine, and psychiatry, which we know behavioral health and all those areas we talked about are very high priorities. So we're excited to be able to see that. And then, of course, other sources we always look to are federal funding. We'll be looking at those opportunities there. And then, of course, a GME formula funding, which I brought before you before, that we get passed through to us that had a higher rate this year too. And then, of course, our clinical trials and research grants that support our research and scholarly activities. We had growth in that area significantly at about $1.17 million in FY20. Next slide. Just as a reminder, the ACGME requires us to make sure we're always assessing our clinical learning environment, and they do a clinical learning environment review visit with us, usually every 2 years. They were delayed, having to be on schedule last year for 2020, but we are in the window, just as we're in the window with Joint Commission, we are in the window for a clear visit. And we look forward to that. So we're in continual readiness mode, working towards these 6 areas that you see here on the slide in terms of our pathways to excellence. Next slide. Also, we're very excited, even through the challenges of COVID, our programs and our graduates did quite well in terms of their board pass rate. We watch this every year. We continue to stay very, very competitive and doing very well in really having high quality, board certified, wonderful graduates out there doing the work and representing JPS in the training there. So 100% last year, which we're still awaiting our emergency medicine as they were delayed in part of their examination, but we're anticipating good results there too. Next slide. So I always like to present to you a little bit in terms of our trends, in terms of that. So it's still pretty much that most of our grads like to stay in Texas. And so as you see that, it's a good investment in our folks that are really serving in that area. And so they continue to stay in Texas at a higher rate. Next slide. This also gives you a little bit in terms of our graduate retention trends. And so just to summarize this slide, A few challenges with COVID, but I just want to say I'm very, very excited and I'm very pleased and grateful to work with our physician partners, our Acclaim, IAS, Sound Physician too, in terms of hiring our folks and keeping them here at JPS. We had about 12% stay at JPS and then about 26% stay in the Tarrant County area and about 38% in the DFW complex. Most, as I said, stay in Texas, so that's still a great thing. We continue to work very closely on this, and hopefully we can continue some efforts in terms of recruitment and retention around that. Next, I wanted to see the next slide. So let's talk a little bit about demographics. So one of the areas that we've also been focusing on is how do we actually improve our gender diversity here. We know that in our medical school class, we're close to a 50-50%, but even in the physician workforce, we're not quite there yet. We are getting there, but in the broader U.S. physician workforce, we're about 64% to 36% male to female ratio. But I will say, as you see the trends here, we have done a significant, great job. I really am excited about our program directors and all of our faculty working very diligently to have more equity in that area. And so we actually have the first year where we're about those trends that are matching our medical school graduate trends. So good to see that. And then on our next slide, we have a few more resident demographics we'd like to share with you and our incoming folks that are coming in as interns. And so one of the things, as you know, we've talked about here and that we continue to look at very closely is what we're doing in terms of diversity and move toward inclusive excellence. And so part of that is also how do we advance the numbers in terms of our URM or underrepresented in medicine residents and faculty across there. And that's a long-term goal, which we understand that. We understand that the pool is still a challenge, but we did see a bit of a shift, which was good. Some downward trends in some areas, and then some upward trends in certain areas identified as underrepresented in medicine. Overall, we went from about 13%. We kind of gradually went from 11% to 12% to 13%, and now at 15% URM. But we are continuing this with lots of efforts that we're doing in this area, and I'm happy to discuss a little bit more about that. But our GMAC did approve in September 2019, a whole diversity and inclusive excellence initiative. What we're focusing on increasing the pool of candidates through different methodologies, reviewing our selection criteria along with some implicit bias training, things like that in terms of also what kind of support and resources we're able to provide all of our residents when they're here in these particular areas of diversity. And we're working very closely, and I look forward to, of course, working with our Chief Diversity Officer in our Diversity and Inclusion Department. Next slide. So impact of COVID, we have to report this impact to ACGME, of course, and of course we want to make sure we report it here. Our residents were right at the front line, right there with everyone else with our interprofessional team. They were critical to providing the frontline services for all of our patients. And so we wanted to recognize that was an impact. They really stepped up to the plate tremendously, and we appreciate that. It also, the expansion of telehealth, they were also integral in that. And so they really learned a lot in that alongside with their faculty working in telehealth models. And then, of course, there were some limitations that happened that we had to assess because some of our surgical specialties, particularly, and also having procedures in some of our other areas too, and clinic visits were slightly impacted when we had decreases in those areas. So we always had to make sure that we were monitoring those closely to ensure that our graduates were graduating with full competency and meeting those numbers, which we were pleased to show that they did. Also, there was an increased need to address well-being of all of our teams. And that is something that we had to really partner with significantly. And I'm grateful for the Care for the Caregiver team. I partner with Zelia Baugh and Laura Burnside and their teams. And we have 4 incredible directors who make up that Care for the Caregiver leadership and really advance that. And I appreciate all the efforts that they do to help us be nimble in this and also be innovative in ways to provide support for well-being. And then, of course, we really had to shift significantly in how we recruited because we were forced to go virtual. This is the first time we've ever had to recruit virtually. And I will tell you, it was a huge lift across this organization. And I want to thank specifically our communications department, Dinah Brodeur, our legal services group and IT, David, everyone that really actually made this happen, along with my entire team here in the institutional office that made this happen, and all of our program directors, program coordinators, making videos, getting everything out there, ensuring that we were fully prepared to do this. And it was very impactful, showing that we were able to fill all of our slots and did not have any slots go unfilled. And we had really great folks to do that. So thank you for that. Next slide. So that part summarizes our annual institutional report, and I'm going to go right into our institutional self-study. So this institutional self-study, as I mentioned to you, is something that's required of the ACGME in anticipation of our future site visit, wanting to ensure where we are and to make sure that we are engaging a team to be able to come up with specific aims that we're looking to work towards that align, of course, not only with what we're doing in GMAC, but with our organization and our community needs. And so we identified our team. Our team was composed not only of myself and my academic affairs leadership, program directors, program coordinators represented, residents represented, and our CMO, Dr. Miller. And we were very excited to have their participation. I want to give a huge thanks to Diana Singer, our executive director, who conducted multiple SWOT analyses to be able to identify all of these data points, put this data analysis in for us to be able to review. And then, of course, this went to the GMAC, this was presented to the GMAC and the MEC, and now here, and also with Robert Early as our CEO to ensure also presentation to him also. So we're presenting it to you at this time in the next slide. And with that, we're going to just briefly tell you what our major themes that came out of those SWOT analyses were. And so we have our strengths. We're definitely just understanding the widespread support for GME that you recognize and what you were able to really invest in us. And so that was definitely a strength recognized by all of the key stakeholders across the network, and realizing that we do have an incredible learning environment for our learners. I just spoke with one physician leader just today talking about our residents and how she said they're absolutely amazing. And even hiring them, she said the quality, the faculty often said, and the other physician colleagues say, wow, where'd you get these folks? They're like, they're our own. They're really amazing. So I want to say that thank you and thank everybody for the work that they do. A couple areas of weaknesses that we want to look at, I think is not news to anyone, is that we are in the process of getting more space. And so we want to look at that because that is a challenge as we look at opportunities around educational space. We're always looking at that and hopefully looking future for simulation, other things that we can do to be able to provide those educational needs for our programs across the board. And then, of course, needing some increased faculty development and resources. So we're going to be exploring how we can really improve that for our faculty. Some opportunities also as we're growing and expanding clinical services for our patients, we want to think about what associated training programs can go along with that. So, we've talked about it before. We are always looking for opportunities for expansion of our graduate medical education program and to better serve not only our learners, but to serve our patients and communities. So as we do that, we will be looking for opportunities to grow in those areas that are needed for our patients. And then, of course, expansion of the infrastructure to meet all of our clear priorities. That's the ACGME Clinical Learning Environment Review priorities. So those are opportunities we're working across the network to do. And so we thank the partners around that. And then threats of that is that we have some things here that we're looking to do in terms of the growth. Just there's growth of local GME. And so those are things that we are really trying to make sure that we are working on and looking at, so that as the local GME grows in other areas and other hospitals, where are we in that collaborative model and make sure that we are also growing. And then I think the other piece that we are looking at too is that we don't necessarily have all the services here at JPS sometimes. So sometimes there's a reliance in some of our participating sites to be able to meet those ACGME requirements. So as we grow, we're hoping that we can make sure that we're retaining some of that here and being able to do that. But that is something we're always having an eye on. Next. So I just want to summarize to you the aims that we have here based out of these SWOT analyses of what we're doing. And so here we have definitely looking at expanding our culture for well-being. That is something that is still very critical. The ACGME looks to us for that too, by our residents, our fellows, our faculty, our GME administration, and the whole interprofessional healthcare team. As I said, I'm really excited to work with the Care for the Caregiver team, but we also are working very closely with, I'll tell you folks like our JPS Foundation. I mean, they've helped us really look at some things to be able to shift gears. We have something now we call smart counseling. So that's also something where we're able to provide more of a virtual connection for counseling services that we're hoping can help. And they've been instrumental in helping us do that too. So we appreciate that also. And then also aligning our curriculum with patient safety and quality, continuing to work on diversity and inclusiveness. So that is really very important with us. That is a long-term goal. As I mentioned, we are not taking our eye off of that. We're excited also to work on some things there where we've already started looking at building some pipeline programs, even as we've talked about here at the board through our high schools. We've actually made connections already with Fort Worth ISD leadership. We're working on some things we hope to bring back to this board to be able to build a little bit more of. We're also working on, with foundation and things like that to say how we can look forward to building some of these here at JPS. Research, scholarship, and innovation have to be a part of this, and so that's what we're going to continue to do that. And I'm excited about Mark Holman being here too, and then partnering with him on these areas of advancing our research, scholarship, and innovation. And then, of course, faculty development and education. So we want to foster that lifelong learning, so we're going to make sure that we're focused on the needs of our faculty also in these areas. I want to thank you guys. I just want to say that, just as a reminder, we do have Research and Quality Symposium coming up June 4th. And I hope to see you guys there. You've been wonderful support for us in that. We have over 220 plus abstracts already. We have a former Surgeon General as our keynote speaker, which will be exciting. And I know Dr. Weber excited about you also being there, and Robert. So thank you all, and I wish you well, and I'm open for any questions.
Hey, Dr. Elliott, Trent Petty, thank you very much for that. I have two questions, one just for education and one, I guess, your opinion. As we look at our resident programs in GME, do you believe that we gain any advantage or create a more attractive circumstance if we were to offer resident housing close to the campus?
Sure. You know, I think that's something that some programs across the country have done. And I think it can be, when you're seeing it in the comparative rates, if there's something comparative where you're having some cost effectiveness compared to what's out there in the neighborhood, right? That you're showing them that it's either subsidized or it's in some way more competitive for them. I think it can be definitely an incentive in terms of our recruitment for folks. I'll give you for instance, when I moved to New York City to do my internship, I lived in resident housing right there by the hospital. And it's the only reason I stayed there for the time that I did was because the cost was just more cost effective. So I think there's some things there, but I think we also realize that many of our residents come with families too and things like that. So there are things we'd have to be able to offer them to make sure that there's a true support for them, not only them, but their families too. And I think we did some assessment of that in the past, and there was some uptake of interest, but I think we could always look at that again if we need to.
Well, I ask because obviously we've got a program started that would give us the opportunity to participate in some tax credit related multifamily, and there's no limitation on a program like that when it comes to being able to offer even 2 and 3 bedroom units associated with the hospital. And I presume that we would be more appealing if we had that kind of access. I just didn't know if at the end of the day, does the end justify the means? If we're getting everybody we want and there's no need to do that from our perspective, it's a little different doing it out of benevolence and doing it because we really want to increase our attractiveness. I just wasn't sure which one of those you thought might fit.
Yeah, I think we could take a look at it again, Trent. I think I'm happy to look at that. I think the last time we looked at it, it's been about 4 years or so, 3 or 4 years. And so I think with all of the boom of housing that we've seen around the area here, just in the time I've been here, maybe it is a question we could probably look at more recently and see what the interest is, if you'd like us to. So.
I would personally, because if you look at the rents in the hospital district, I mean, they dramatically increased over the last 4 to 5 years. It's not uncommon to encounter $225, $240, $250 a foot rates. And for many residents, that's going to be a prohibitive cost. And to me, it's better if the hospital has those folks where they're a few steps away instead of having to Uber or, drive or, potentially have to do that just to get lower cost housing. And it's a long way from here to get lower cost housing.
Great. Yeah, happy to look at that. And I'll work with
Trent. One of the other things we saw, Trent, and I know Dr. Elliott is aware of this from her days of being a resident, but one of the things that we found in a study in Arizona that asked that very question about housing for students and upper level courses was getting a 4-bedroom apartment and having 4 people in the room, or, just kind of having a place, because really as a resident, you're going to sleep there, you're going to get up, you're going to go to work. And the luxury of being, reducing your cost even in affordable housing is a plus. And then you get the ability to sleep 4 or 5 hours, and then you're up and you're doing it again, and you go back and you sleep 3 or 4 hours. That close proximity, at least in other studies, has proven to be hugely beneficial. And to Trisha's point, at this point, the margins of competitiveness are so fierce in residency programs. It seems to me any value add you give is a plus. Any little thing that residency X and Y don't have and we do have seems to be a beneficial aspect of it. So I think your question's great, and we'll definitely look more into it. But a lot of our preliminary studies have shown that tends to prove valuable from a value add standpoint. Housing does.
Great. I have a second question, and I'm probably the only one on the board that doesn't know the answer to this, but I'm going to look stupid and ask it anyway. What goes into, you told us that we got additional money for existing residency programs and the sources of those funds. What does the process look like to get a new residency program?
So to actually get a new residency program versus the funding for it, or both?
Yeah.
Yeah, so the process for doing a new residency program is that basically what we do is we start off and kind of seeing where we are in terms of the services offered, and do we have the capacity and the capability to be able to fulfill that. And so if there's a need that's here that we're looking at, but we first have to see, are we meeting the requirements? So every program and every discipline within the ACGME have specific requirements. And so we have to thoughtfully look at all of those requirements and then assess and kind of do a gap analysis to see, are we able to meet those, whether mostly, hopefully, internally here, or are there other partners around the DFW area that can help us to meet the requirements that are reasonable to do so. So in doing that gap analysis, we do that. We also do a pro forma. I asked them to do that. Do we have also the visits? Do we have the procedural capabilities to do this, the numbers to do this, all those things? Do we have the capacity? We work with finance. We work with the program directors, the service line administrators. We come up with those pro formas and we look at those very closely. And if we kind of say this isn't the time, then we're like, it's really not the time. If we feel like there is an opportunity there, then we'll go ahead and move forward with getting all the things in place and submit the application to the ACGME. We have to fill out a full thing, what's called a PIF, or Program Information Form, along with the other documents that we have to submit. We go ahead and we get to that point submitting, and then we await the review and we await the decision from the ACGME review committee for that particular specialty to let us know if we're approved. If we're approved, then we decide what the recruitment timeline would look like for that and filling that. And of course, making sure all things are in place, right? So the finances are in place, everything is in place, and that all of the specialties and requirements are in place. Usually they'll go ahead and say they'll give us a preliminary accreditation for those programs. But usually with new programs, we can always anticipate that they will come on site, usually within a year, within that year, to do an on-site site visit to make sure we're doing what we said.
Great. Thank you very much. This was helpful. There's some good information here I wasn't aware of. I appreciate you taking time to show it to us.
Sir, thank you.
Dr. Elliott, this is DT. I have a question on page 55 around incoming JPS residents.
Okay.
And I'm not sure if we...
I am here too. Go ahead. Yes, no problem.
As I'm looking at the last few years, the number for African American, Hispanic,
yes,
is pretty much the same, and the Asian dropped from almost by half, from 21% down to 12%. So is there a have you guys visit that and see what will it take to see if we can increase some of the number for the Hispanic population and the African American? And what went wrong with the Asian population from a JP resident's perspective that dropped so much?
Okay, can you tell me which page you're on again?
It's page 55. It's around incoming JPS resident.
Okay.
It's page 27.
Okay, thank you. I appreciate that. Okay, so when we're looking at this, actually, so hold on a second. So yeah, so when we're looking at the Latino, this is our total with the incoming. We actually have some updated data. So this was before I actually got the match, and so I can give you a little bit more data on that one. So if you look at what the presentation, and maybe David or Jeff, could you go back to a couple slides for me so that I can just make sure to include the 2021. So I want to show you the 2021 data was in this one because we didn't have it in time for this. This just came out when we just got our recent match, but I decided I wanted to include 2021. The one that you have in your executive summary is for academic year going through the 2020. So we actually have made, there was a little bit more in terms of the Asian. We did actually make an increase in our Latinx population from 8%, self-identified from 8% to 10%. There was a slight decline in our Black area there too. We did have for the first time 2% identifying in the URM area of Native American and Alaska Native. And so that's an area there that we do have. We are definitely looking at all of these areas for sure. And I just have to remind everybody what the challenge is that our graduate pool from medical schools, the African-American, the Black medical school graduate population is about 6.6% this last data as per AAMC. And our Latinx is about the same at about 6%. Our Asian graduates in medical school overall are about 22%, and our Native American Pacific Islanders in that group is about 0.2%. So our overall underrepresented in medicine nationally from the pool of medical school graduates is about 13%. That's U.S. grads though. So that's just all U.S. grads unless we start looking at that. And that's most of our folks are U.S. grads, but we do occasionally have some international grads. But the challenge is that we still have a very small pool. I will say comparatively, we've made some strides, but we are looking at this as a very long-term goal. I will tell you through some of the things we've talked about, we're doing things where last year COVID kind of put a little hitch in that, but we started doing some things in terms of trying to increase our visibility and increasing our pool of candidates through that visibility. So we are participating now in even some national efforts, such as with the Latino Medical Student Association, LMSA, SNMA, Student National Medical Association, all of these areas that we're actually going to. So we are participating in their national conferences and making sure that they know who JPS is and that we're here. So we actually started that. We're also, as I said, going to be working with some pipeline, trying to build some pipeline programs locally. That will be, of course, long-term, looking at those, working with our STEM schools, our health science technology programs that are here in Fort Worth ISD. We've already started some of those conversations. We're going to be also looking at the HBCUs that are local, the historically Black colleges and universities, the Hispanic serving institutes too, HSIs, and looking at those areas. So we're looking at a broad-based area, but we did make a shift in that. But yes, we have increased our Hispanic Latinx, went up a bit in the Asian area too. But as I said, we're always looking at this, particularly the URM piece too, to make sure, but across the board, just looking at our diversity across the board. I hope that helped
Dr.
a little bit. Yes, Reverend Emerson.
You mentioned ACBUs. You haven't made contact with them as of yet then, right?
No, I'd love to sing. We have some thoughts. Yeah, we have not yet. We did do one thing because we had actually some initiative 2 years ago, a year and a half ago, like right before COVID, we had one of our residents who was a grad of Howard, actually. And then a couple of our residents actually they wanted to go to Howard or just engage with them in some conversation. So they did that. But for the Texas schools that are local here, we're definitely wanting to partner with them, especially those that have some strong medical programs like Prairie View and otherwise too that have those. So I'm open to all those, Reverend Emerson. So if you have any of those contacts, and I'd love to hear them. And yeah, we're looking forward to taking that as the next step. That's just part of our timeline process to do those engagements.
Okay, I will follow up because I had mentioned it before, and there is an organization connected with the HBCUs that recruit students and seek to place them at spots at healthcare facilities throughout the country. So I will get the name of that gentleman and refer to him. I thought that had already been done, but I'll follow up on that.
Thank you, Reverend Emerson. I'll do that.
Dr. Elliott, do you have the name of the 17 medical school that has a high percentage of African American students, medical students?
We have that somewhere. I do not have that in front of me. I do have some areas where we could look at of course, the 4 HBCU medical schools that are around that probably have some of the highest there that we're looking at partnerships and stuff. And I have some contacts that I've made there as we look at those 4 schools. And those are Morehouse, Meharry, Howard, and Drew. But the other non-HBCUs that we had, some of that data is actually in the AAMC. And so we do have some of that to kind of show that. But if you have any other information, I am open to it. Please send it my way.
I'll send you the top 17 school that has a high percentage. And then maybe we can target those schools for that.
Thank you so much. Appreciate that.
Dr. Elliott, this is Cheryl.
Yes.
Can you hear me? I just, if y'all would indulge me, I just wanted to take a moment, since it is Thank You Week, to thank Dr. Elliott, Diana Singer, Carolyn Diaz, and Racine, and the whole crew. This last year with recruitment and everything, they made it so smooth. It was very scary as a program director having to be like, what do you mean I can't have in-person interviews? How am I going to pick good candidates? And it was just wonderful. The resources they gave, all the stuff they set up for us. We didn't have to do it on our own. They standardized it across the departments, used in my opinion, an absolutely excellent platform for it. And then also, in my opinion, I think all the programs are actually super pleased with the interns coming in. It did not seem to have as big a negative impact on our resident recruitment as we were worried about. And I just wanted to give a big shout out to all of academic affairs. And again, especially for this Thank You Week, say thank you guys for all that you do for our learners here.
Thank you, Dr. Hurd. And thank you for what you do too. You do so much, and I appreciate you so much. Thank you.
Any other comments, questions for Tricia? Tricia, I have one, and that is you and your organization are recipients of one of my many thank yous.
Oh, thank you.
I think what the group was able to do in this COVID past year is just unbelievable.
Oh, thank you, Dr. Weber.
And I once again just say for the community at large that the graduate medical education is one of the hidden jewels in the crown that needs more exposure, for lack of a better word. So thank you once again.
Thank you, Dr. Weber. It's my pleasure. It's my honor. And I live my passion every day. And you guys give me that opportunity, and I'm grateful for it. And we are all grateful, our whole team. Thank you for it.
Since we have 2 people today that are from Ohio State University, they have 13% of students who are African American in their medical school. They have one of the highest percentage.
Very good.
Maybe we can make them feel guilty and start recruiting for us.
Like that.
I'll make them feel guilty when Michigan finally beats them in football. Okay, that's it for that one.
Thank you.
Thanks again, Tricia. Next one is review the JPS strategic plan, Robert Early and Ms. Lauren Poe.
Yes, sir, Mr. Chair. What we have, and we sent this to you all, you have a document that outlines the compilation of the work that the board and we as staff have done. This is an incredibly well put together combined effort on behalf of the staff and behalf of the board. You all know we had the one-day retreat for the board. We had the one-day retreat for the staff. And what you now see is the document that has it. Ms. DuBose had a very good point, and that is, as we're discussing the preliminary aspects of strategic planning, it might be very wise to take that up in closed session, because we're going to be discussing a lot of different initiatives by JPS, at least the upper levels of those. This plan, as you all well know, and DT reiterated this very well at the retreat, this is not the tactical plan. This is not the plan that says we will build this, this, and this, and we will put this, this, and this in place. It is a directional map for JPS, for you as a board to help us as staff as we try to figure out what's best for our patients and what's best for our taxpayers. So, Mr. Chair, if you don't mind, we'd very much like to have this discussion enclosed so that we can begin to have that discussion. And I think we'll see where that discussion goes.
Okay, Daphne, is that okay with you moving it from open to executive session?
Yeah, we do have portions of that plan that hit the hit items that should be discussed and closed. So I did discuss that with Mr. Early and Ms. Poe, and we can just take that up in executive session.
Okay, great. Well, we will do that. Next thing I have is committee reports and action. The first is the finance committees. Steve Montgomery.
Thank you, Mr. Chairman. On April 22nd, we had a finance committee. It was nothing short of fantastic. It was probably, people are still talking about it. Wow, what can you say? I mean, it was just one of those events. Ms. Clark presented our March financials. Our year-to-date numbers are quite great. Very happy about that. There's still some uncertainty between now and the end of the fiscal year, as there always is, but feeling confident about where we're standing right now. And we passed forward for the full board's consideration several contracts. David Mendenhall is spinning like a drunken sailor, but we're getting lots of important IT equipment. And there were a couple of other contractual items in there, so we recommend approval by the full board. That's my report, Mr. Chairman.
Okay, comments, questions for Steve? Don't hear any, so the next one would be governance committee, Roger Fisher.
Thank you, Mr. Chairman. I can tell you, we know it will always be a successful governance meeting when we log on and Steve Montgomery's face is no longer in the chairman's position. He is done early and on time. So we too held a very successful meeting. We discussed a 24-month look back of the My Texas Workers' Comp update. By the way, conflict of interest statements are now done electronically and I believe are due tomorrow. If you have any questions and can't get logged on, Michelle Atkins is the point of contact. If you have questions regarding the form itself, it's a little bit different. You can reach out to Daphne and we can get those answered. But those are due tomorrow. And now we're tracking you so you know you'll get a personal phone call from me if it's not done. We had an update on kind of a mid-year review on the compliance and internal audit work plans. I made some minor adjustments to those. And on the agenda is LD 3700, which is an archive of marketing procedures that was passed without objection. That's all I have.
All right, comments, questions for Roger? The next one I have is the quality committee, and that committee met on Thursday, the 6th of May, 2021. And I'd like to mention 4 things. Number 1 was the leapfrog score was a B, where it had been a C. And the preliminaries for that report were, I believe Diana sent them out, but they're, once again, congratulations to everybody and thank you. The next one I have is Laura Burnside presented the patient experience, and there are 2 that I'd like to mention, and one is the organizational goal for the inpatients, and we are just short of the threshold for meeting that one. And then an organizational goal for medical practice for outpatients, where we have exceeded all of our metrics and at that 68.5 top box. Pretty good, I would say. Next, Rob Stevenson presented the COVID-19 update. And the next one was the PSI 90, which is the Patient Safety and Adverse Event Report. Where we fell off a little bit was in pressure ulcers. That's a very complicated topic. It's multifactorial. And most of it is aimed at the COVID-19 patients that had to be treated in unique and novel ways in their positioning in the unit and some of the transient folks that come through and take care of people. And I think that's, hello. Rob also presented the program for the data for the infection control initiatives that'll be going on for this next year, with good summaries of weaknesses and the goals that needed to be obtained. Anybody that wants a copy of that, just let Suzanne know and she can get it to you. And that's it for me. If anybody has any questions. I don't hear any. Next thing I have is the consent agenda, and all these items were discussed in board committee meetings and may require little or no deliberation by the Board of Managers, but they require board approval. And if anybody would like to discuss any one of them, just give us the letter and we'll pull it off. I don't hear anybody. So then I'd like to entertain a motion for the approval of the consent agenda from A through U.
This is a move to approve A through U.
Charlie, I'd move for. Yeah, I'd second, Chuck.
Okay. Discussion by anybody? All in favor, please say aye.
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 Anybody opposed, say no. Not hearing, motion passes. Next I have is the Law Department quarterly update from Daphne Walker. But before you start, I have a question for you.
Okay.
When will we be allowed to go back into sessions where we're all present? Any idea, since that's a legal?
Yeah, I don't have the date, so the emergency order that allowed us to do this online has not been lifted. I do know that it was mentioned as part of our internal discussion that we were going to be looking at that to give a proposal about when we could return live.
Okay, so we'll just wait to hear from you.
Yes, sir.
Okay. Well, then it's all yours. Law Department quarterly update.
And I do think we have a visual, if we can pull that up. I had mentioned to the board that I would like to give, now that we've got an in-house department, more of an operational update for the department as opposed to just giving a contract number. I think you saw the report in your portal, and I'll ask IT one more time to pull it up. But if not, I will go ahead so we won't delay the meeting. But what's included on that report, just for your information, you can go ahead and go to the slide, is a contract summary, litigation summary, collections update, and then some just project wins and trends and other. And that will be the look of the report going forward, so that we can give you a little bit more information about the operations. And of course, we'll get into substance in the closed session. So the top left-hand corner shows our contract summary for the quarter. It's now going to be reported as a quarterly number. The 155 is actually a typo. That's actually the total number, but we did have 155 total contracts for the first quarter, and that's calendar quarter, not fiscal year. So Q1, January, February, March, 155 contracts, and those included 5 that were exemptions that were approved by the board, and 21 that were awarded through RFP. If you want an idea of the breakdown of the rest of those, about 34 of those were just contracts and amendments that had no spend associated with them at all. Those were primarily our grants and academic arrangements. We had 80 contracts that were under the $50,000 threshold that don't require a bid. 13 were from our GPO, Vizient. And we had, as I mentioned, 21 that were a result of RFP. We had 2 that were professional services exemptions. Moving down the page to the litigation summary, right now we have 12 open cases. That includes med mal litigation and other litigation. We have 3 cases that were were resolved in the quarter and 6 HR charges that have been filed with the EEOC. The top right-hand corner, for those of you who don't know how the law department is involved in collections, so we do have a contract with the DA's office. They also assist us with our medical malpractice cases and some of our contract work. But another thing that they do for us is they handle collection matters for which there will be third-party liability or in which an attorney or insurance company has notified us of representation. This can include motor vehicle accidents, auto pedestrian accidents, falls, dog bites, et cetera, anything where there might be third-party liability. And they'll work these cases until resolution or until there is a determination that there will be no third party who's responsible for the payment. And then those are treated as self-pay claims. And if they're delinquent at that point, then they'll forward over to our third-party collection agency. They do a really good job for us. For the quarter, we concluded with 53 open cases still remaining that they're handling for us, and that was totaling about $2,920,013, and you can see that represented on the blue bar there. They were able to close 78 cases in the first quarter for a total amount collective of $767,351. That represents roughly 26% of what was outstanding. So again, they do a really good job. I think the district has been really pleased with the support that we get from them. And then finally, in that last box over there, just some high-level information so you kind of understand what's going on with the department as a whole. We are really making good progress toward our first-year goals. You will remember when I started, we kind of laid out what should this look like as we begin to evolve a program and build an in-house legal infrastructure. So we're now transitioning from building the infrastructure to really focusing on process and systems. And in that, of course, is going to be included the education that we talked about, both for the board and the internal leaders. We are also tracking savings. That's something that's always going to be on my radar. So we look very closely at outside counsel spend. We had anticipated that we would likely see an increase in spend given the ramp up, but we're actually already starting to see a projected savings trend, even taking into account in-house salaries. So the range there that's on the graph for you, on the low end, that would be roughly $900,000 in trended savings. So that's for the year. I've only been here for about half of that since I started. And that would be pulling in-house salaries out. If you only looked at it on a spend basis, then you're looking at closer to 1.3 million in trended savings. And again, those are projected numbers based on the decrease we've seen to date. A little bit on department updates. We, as you know, had done a little bit of a staffing analysis. So as we started to move the work that was being done by outside counsel in-house, we had already added one attorney. We have another attorney that will start at the beginning of June. We are recruiting an executive director of contracts to lead that team as we continue to look at our processes and make some improvements there. And we also are, we had a senior paralegal. Unfortunately, she had to make some changes for her family. And so we are just going to backfill that position that we already had originally filled. And then as far as trends and other, this is just, I'll just give you there a little blurb that we're seeing either on the contract side or just that, you know, we're kind of keeping an eye on internally. Generally, we, from a contractual perspective, have definitely seen increases in our attempts to cap liability for business associates. And I know that the board had some really good questions at one of our committee meetings about that. So we are watching that closely and making sure that we are not losing opportunities to make sure that we're protected as it relates to potential HIPAA breaches. And then as far as our Public Information Act requests, we had 24 in the quarter, and we did brief 2 of those with the the Office of Attorney General. And that's it for the open session report, Dr. Weber.
Okay. Comments, questions for Daphne from anybody?
Hey, Daphne, this is Steve. Just one humble request. I love the format of the presentation. For us old guys, would you mind making the font a little bigger? Like, it's really hard to read. Thank you.
And as blind as I am, you would think you would not have to make that request. So I will gladly grant that for you.
Thank you. Thank you.
I agree. Okay, I don't have anything else for open session. Y'all want to take a 5-minute break? Looks like heads are going up and down. I can't tell. Or you want to keep going?
Well, Dr. Weber, this is David. We just need a couple minutes to get to closed session. So we need about 5 minutes, and we'll do that for you. And then, as Mr. Montgomery said, the drunken sailor will then come back and let you know when we're ready to go back in closed. Okay, right. So give me about 5 minutes.
Okay.
Okay, then we'll come back at 1500 hours.
Clive.
I'd like to reconvene in open session for deliberation and or action deemed necessary regarding any matters that's on the executive session. And I have two. The first is privileges. Cheryl?
Thank you, Mr. Chair. I'm just seeking board approval of the credentialing and privileging packet as presented in executive session.
Chuck, this is Steve. I move for approval.
This is Zim. I move second.
All right. Any discussion? All in favor, please say aye.
Aye.
Those opposed say no. Motion carries. The second one that I have goes back to open session item 9C, which is the JPS strategic plan. And what I'd like to do is have an approval to proceed with the plan as presented. And I'd entertain a motion and a second for that.
Move for approval.
Move for second.
Any discussion, further discussion? All in favor, please say aye.
Aye.
Those opposed, same sign. And I don't think I have anything else for the meeting for today. Does anybody else have anything they?
Mr. Chair, Mr. Chair, we started this meeting with thank yous to you as board members, and we want to end with a thank you. To have the strategic plan move forward is, I think, a great initiative on behalf of the board and behalf of staff. To have the report out from Daphne and Legal Services is a benefit as we move forward and we make tough decisions. And for those of you as board members that have given so much, we are grateful. And again, I want to end with a thank you because y'all have been very powerful to this staff.
Okay, no other comments. It's 3:55 or 15:55 hours. I entertain a motion to adjourn.
Move to adjourn.
Bye-bye.
You need a second?